Well, thanks, Brian, and thanks, Kent, for having me. It's great to be back with everyone. I'm going to talk about pediatric HIV today, and this is a topic which probably a lot of you out there are not actively participating in on a regular basis, but the chances are that you just might have a kid with HIV show up, or at least an HIV-exposed kid show up in your practice, and it's nice to have something in your back pocket to reach for. Part of the reason that we don't see this much in the United States is because the prevention of mother-to-child transmission of HIV is so effective with our current antiretrovirals. And so there's just not a high volume. Most of these kids are seen by pediatric ID specialists. But it's really important to know a little bit about pediatric HIV because this is really a very different disease than HIV in adults. It's been said that children are not just small adults, and that couldn't be more true than in the HIV, where pediatric AIDS really is a much more aggressive disease than adult HIV. So I thought we'd spend a little bit of time on that today. So my first slide here is the latest version of the guidelines. Of course, we refer to these often, available easily at aidsinfo.nih.gov. And these were last released in November of 2012. Not much changing in the adult guidelines these days, except for a couple finer points, but actually the pediatric guidelines are changing quite a bit, mostly because the antiretrovirals are continuously adapting to pediatric formulations, albeit usually 5 to 10 years behind the adult formulations. So here's the outline of what we're going to talk about today. First, a really important skill, probably the most important thing that you will be confronted with in clinical practice, is how to diagnose or exclude the diagnosis of HIV in an exposed infant. Just like we've had several times in our echo cases presented, we need to know what's in the guidelines, what people kind of do off the cuff, off guidelines, and how to interpret the tests. Secondly, when to start ART, and then thirdly, what to start. These are kind of the central questions in treating HIV of any age, and they definitely are different and probably with a little less evidence in pediatrics. The what to start question actually gets quite complicated because if you're an evidence-based medicine type of person, there's just a whole lot less data on most of our newer antiretrovirals in kids, and I'll talk about that. And then finally, we'll finish with the Mississippi Miracle, as it's been called. The second patient ever to be cured of HIV, at least this documented case, presented recently at the CROI meeting, and it's caused quite a stir in the media. I'm going to go through some of the details of the case, and then most importantly, talk about the implications and what does this really mean on a practical basis for patients living with HIV, and what does it mean more in terms of research directions. So let's start with the first topic of diagnostic testing of HIV-exposed infants. So we're going to start with the question of how to diagnose or how to exclude the diagnosis of HIV in an exposed infant. And I want to start with the point that serologic tests, or tests that search for HIV antibody, are still valuable in certain subpopulations of infants. Namely, if the infant is greater than 18 months, or in a non-breastfed infant after 6 months of age, you should probably wait at least after 6 weeks after the cessation of breastfeeding or after weaning. But serologic tests actually can be used to diagnose infants. This is mainly kind of in resource-limited settings or in places where an infant has presented well beyond the perinatal period. But the name of the game really in pediatric HIV are virologic tests, and so these are RNA PCRs and actually DNA PCRs, and the difference between those two, just before I go on, is that of course DNA PCRs are going to amplify DNA that has been already reverse transcribed and encoded into PBMCs, and so it's really kind of a more true way to tell if the baby has in fact been infected. The guidelines don't really differentiate between the two, and what I've seen in practice is that typically pediatricians will order one of each because you're going to be ordering more than one to confirm or to a diagnosis. I wanted to show this difference here. You see that I've denoted virologic test number 1 on this timeline, and by the way, this timeline is going to be shown throughout the talk just to show the different ages from birth all the way through 18 months. And when I talk about antiretrovirals, the scale will look a little bit different. But the first recommended virologic test in the guidelines is actually between 14 and 21 days. We very often hear about things being drawn really the moment of birth, hours after birth, and this is really considered optional. for high-risk infants. I personally know a lot of pediatric infectious disease doctors that do it, but the reason that it's considered optional is because the performance characteristics of the test are actually not as good immediately following delivery. Keep in mind that most of HIV infection is thought to occur in the peripartum period. So you have some children who are exposed and don't actually end up being infected, and so both the false positive and the false negative rates are increased if you send that test right at birth, and the test characteristics actually improve from about 14 days onwards. Having said that, the second window of testing that's actually recommended is between 1 and 2 months old, virologic test number 2, and basically if you've had either 2 positives or 2 negatives, you have your answer. So even if the optional virologic test is done at birth and it's positive, you'd probably want to send another one right away at 21 days, and then you have your answer. If it's negative, most people would do a second one, and then because pediatricians tend to be conservative people, and because this is an extremely important diagnosis to confirm, most people end up sending 3 tests altogether. There's actually another window here that's recommended in the guidelines, virologic test number 3, sometime between 4 and 6 months of age. And this is very important. I'll show you in a minute just the general pathophysiology of HIV in infants, that it's a very rapidly progressive disease, so the earlier you can confirm diagnosis, the better. And the treatment strategy really does change significantly. So we go from usually a regimen of prophylaxis, which is usually not a full 3-drug regimen, to something which is a potent 3-drug antiretroviral therapy regimen after you make the positive diagnosis. So let's move on to the when to start question. I'm going to talk a little bit of the supporting evidence base, which is mainly based on 2 important studies, and then we'll go through the guidance. Now we all should be comfortable with this curve that we use in adults, which shows the natural history of untreated HIV infection by CD4 cell count decline. And you can see that we have a little dip in the first year, and then the scale on the bottom here, very important, is on the scale of up to 10 years. And we're all very comfortable saying that no, HIV is not an emergency, and yes, we do want to have early diagnosis, but we've been talking about better outcomes according to years of diagnosis. CD4 decline from, say, 500 or so down to 300, down to 250. Of course, we don't want things to end sort of on the end here, but really the burden of death and morbidity, mortality in adult HIV occurs way down the road, 10 years after initial infection. I want to try to burn into your memory a couple of very different looking curves here from 2 of the main studies that have given us the evidence base for pediatric HIV, and they paint a completely different picture. So this is why I started saying that pediatric AIDS is a very different disease. So let's start here with this study, Newell et al. From the Lancet in 2004. This was a study, I believe, that occurred in Southern Africa, I think South Africa, which was really an observational study and followed infants who were exposed and infected, and then exposed and uninfected for just raw numbers in terms of mortality. And what you can see here on the green curve is the mortality according to children who are HIV infected, and the numbers here are absolutely staggering. So you probably can't see the letters there, but if you look at the primary source, what you're seeing here is that by 1 year of age, there's a mortality rate of over a third, 35% of the subjects were dead at that time. And then by 2 years of age, mortality was 52%. So more than half of the HIV-infected infants are actually dying before the time they reach their second birthday. Extremely different than the slow chronic disease that we're used to seeing in adults, partially because in the developing immune system of the infant, it's just so much more vulnerable to being completely overtaken by HIV and succumb to opportunistic infections. We pan down to the study on the bottom here, which is really the main study that drove the treatment recommendations for when to start therapy. This is a study called the SHARE study, C-H-E-R, published in the New England Journal of Medicine in 2008. Also, I believe, in Southern Africa, although I believe it had international components as well. And it really just looked at the probability of death or a CDC event, basically an AIDS event, from comparing 2 groups, either early treatment or deferred treatment strategy, which depended on CD4 count guidelines at the time. And we'll talk a little bit more about CD4 count guidelines in a second. But as you can see, the curves separate here immediately. the deferred treatment arm within 3 months had an increased probability of death or CDC event, and by the time the study was actually closed by the DSMB, there was shown to be a 75% reduction in death and AIDS with early ART. Incredibly dramatic numbers, and actually way more dramatic than we see with any of the adult studies in early versus late therapy. So what I hope to show you with these slides are just curves that show dramatic early mortality with pediatric HIV, giving us a whole lot more urgency to start ART than we do with adult infection. I want to pivot now a little bit to a question which has kind of been perplexing to a lot of people, to do with CD4 count, and it has to do with whether you use percentage or the absolute number when you're dealing with children. And this is a direct quote from the guidelines in November 2012. It says, although CD4 percentage had been preferentially used to monitor children aged less than 5 years, recent analyses show that CD4 cell counts provide greater prognostic value than CD4 percentage for short-term disease progression. So this is a little bit of a pendulum swinging back and forth, but I actually was taught when I was training that the CD4 percentage is a little bit more reliable, especially in kids who are exposed to a lot of new pathogens, a lot of variability. Turns out that when you really look at the data, the CD number itself is probably just as good. I'm going to show you just a couple of examples here. I apologize for the Portuguese legends here. I gave this this talk last in Angola. But the blue here is the contagium linfocito total, which is the total lymphocyte count, and the red, which is actually not labeled, as the CD4 count itself. And you can see these numbers kind of fluctuate widely. We're talking about numbers of about 3,000 here at the peak between 3 to 6 months old. And if I overlay the percentage out on the next chart here, you can see that it's just a little bit more of a stable number. And so this is sort of the original data as to why CD4% was used. But again, like I said in the statement, really it looks like the absolute number is where we should be drawing the lines. The guidelines do specifically say, however, that if there's a disparity or a discordance between the number and the percentage, that you should always go with the lowest one, again favoring earlier treatment. There's another really important statement before I get into the details of when to start and what the evidence base looks like, that really is kind of a nod to the adult literature that recommends treatment for all individuals with just different strengths of evidence. The statement goes like this: in addition to recommending treatment for all children with AIDS or significant HIV-related symptoms, which is an A1 level recommendation based on that Virologic paper I told you about, the panel also generally recommends treatment for all children aged greater than a year with minimal no symptoms, with the strength of recommendation based on age and CD4 cell count or percentage. And again, this is a direct nod to the adult guidelines, saying that yes, there is extrapolated data from adult populations that the right thing to do is to treat everybody, and it's now a question of how good the evidence is. So here we're going to get a little more specific and look at the actual evidence. As you can see, based on the Virologic paper, infants that are less than 12 months who are diagnosed early should all be treated based on incredibly high mortality and the 75% reduction in mortality from early therapy. And then between 1 and 2 years, you have a CD4 count threshold of 1,000, really with just different levels of evidence and different strengths of the guidelines. So treat versus consider, whether you're above and below. And then 3 to 4 years, the CD4 count numbers change a little bit. 750 is really the threshold of treat versus consider. And then at greater than 5 years of age, you can see things have fall much more to what the adult guidelines look like, where treat is for the first 2, and then consider for the 3rd. But again, I already went over the blanket statement that everybody should be considered for therapy. I just wanted to remind everybody that Bactrim or Septra or cotrimoxazole prophylaxis is also a very important consideration, and there's fairly good evidence that every infant, no matter what their CD4 count or CD4 percentage is, should be on Septra or Bactrim or cotrimoxazole prophylaxis if they're less than 12 months of age. And that is because a lot of the mortality, a lot of the early mortality I showed you is due to pneumocystis pneumonia. And there's actually a lot of other benefits to using this drug in places like Africa, resource-limited settings, because of its effects preventing bacterial illness and severe sepsis and salmonella infections, as well as malaria. You can see the other thresholds here. Greater than 6 years old, it's basically the same as the adult guidelines, and then 1 to 5 years, a higher CD4 count threshold there at less than 500. So let's turn to what to start, which gets to be a little bit more complicated in these populations. So I'm going to start here with the preferred regimens for ARV-naive children, and this is delineated in the guidelines. And you can see here on the top I've done just the backbone, the NRTI backbone. And you can see that it's a little bit different depending on age. You see a couple different subdivisions here for any child. Really, zidovudine plus 3TC or FTC are felt to be safe with A1 recommendations, A1 level of evidence. This goes way back to the original 076 trial, which I believe was published in 1994 by Connor et al. Lots of experience with zidovudine, and although we know that it causes significant anemia when used for prophylaxis and also in infants, it is felt to be very safe and non-teratogenic. Abacavir medication or a recommendation down to 3 months or older, and then tenofovir gets really interesting here. So we're going to go through the difference between FDA approval and what's recommended in the guidelines. But really, tenofovir in terms of guideline-based recommendation should not be given until you have an adolescent with Tanner stage 4 or 5 sexual maturity. And if you don't know your Tanner scales or don't remember them, this is really a fairly sexually mature adolescent who is basically almost an adult. So we're talking about sort of 13, 14, 15-year-old individuals. And this has to do with the concern for tenofovir, which we have in adults about bone toxicity and decreased bone mineral density, which is amplified in the setting of an adolescent or a young child who has markedly increased bone turnover and growing bone as well. So although tenofovir has approval from the FDA down to a lower age, which I'll talk about in just a second, it's really only guideline recommended if you're in a situation where you're an adolescent. Of course, with highly treatment experienced children who are having virologic failure, kind of all these rules go out the window and you'd basically be off-label. Now, in terms of the third agent here, this bottom part of the table, I mentioned NNRTIs and PIs, and you can see that really from 14 days on, lopinavir ritonavir is basically the AZT of the other class. It's a lot of experience going way back to even early antiretroviral therapy with kids, available in a liquid formulation, and so really a lot of experience there. More than 3 years of age, we have another option. Efavirenz has approval down to that age. And then greater than 6 years, and this really just has mainly to do with the populations that have been studied and the ages that have been studied. We add in atazanavir and ritonavir as well, all with very good evidence, A1 level evidence according to clinical trials. Now, for the next couple of slides, I just wanted to give you a visual representation of some of the things I've already talked about. And you can see on the bottom here, this is the age timeline. It's a little bit different than the initial one because it goes up to 18 years. But what I've shown you here by class is in purple, basically the FDA approval line. So anything that goes down to 2 years, for example, for tenofovir, given FDA approval. However, I've overlaid the green, which is kind of the green light from the guidelines committees from DHHS that says this is really a recommendation. So as you can see, the one interesting thing here is tenofovir, FDA approved all the way down to 2 years of age, however really only recommended late in adolescence, Tanner stage 4 or 5. That's why you see just that small green bar there. AZT, as I mentioned, lots of experience, felt to be very safe except for causing anemia. 3TC and FTC also very safe, and then abacavir, same issues with HLA-B5701 positivity that we deal with in adults. However, FDA approved and guideline recommended all the way down to, I believe it's about 2 months there. D4T and DDI do have FDA approval, however they don't really show up anywhere in the guidelines because of their known toxicity. When we move to the PIs, it gets a little bit different. I have 2 shades of green here, the dark green for being preferred and then the light green for being alternative. As you can see, lopinavir, ritonavir, FDA approved and recommended all the way down to 14 days of age, way up through 18 years. And then atazanavir, ritonavir gains approval and recommendation, guideline recommendation from 6 years onwards. Darunavir is a kind of a newcomer here, and it's been approved all the way down to 3 years, and it's been a very useful agent for people to turn to in terms of highly treatment experienced children who may have protease resistance. Fosamprenavir, not really used all that much anymore, but it does have an indication down to a pretty young age there as well. And then nelfinavir and typranavir, although they have approval, are not really recommended, and indinavir and sequinavir have no approval for this age group at all. Now things start to get a little thinner here when we get into the NNRTIs and other agents. You can see that nevirapine really has a long track record and a lot of experience here, and yet it's not really the #1 guideline recommended agent. And this has a lot to do with the history of pediatric HIV in recent years. So if you know about the history here, nevirapine was one of the first agents really approved and widely used for prevention of mother-child transmission because it could be used in a very easily implementable dosing scheme where you'd give one dose really to the mom, one dose 12 hours later, and one dose to the baby. The problem with this, it was very cheap and very effective. I think it was $4 a pill initially, widely used throughout Africa, and really prevented a lot of babies from being infected with HIV. However, as we know, nevirapine, just like efavirenz, has a very long half-life, and so babies that were exposed and eventually became infected had a long tail of exposure to nevirapine, and in some studies 60 to 70% of them developed nevirapine resistance. So in terms of treating infants that are HIV infected, really not a preferred agent. Efavirenz is the better NNRTI and can be used down to age 3 months. Etravirine, also like darunavir, a very welcome addition to the armamentarium here. FDA approval down to 6 years of age, not really a guideline recommended agent. And then rilpivirine doesn't really have any indication in children. Finally, when we move into the sort of other classes of drugs, not a lot of experience here at all, especially because they're very new drugs. Although raltegravir does have FDA approval down to 2 years, again used in some salvage situations. T20 approved down to 6 years, not really used all that often at all. And maraviroc and elbaptegravir really not studied adequately at all in children. So I'm going to turn now in the last couple of minutes just to briefly run through this amazing story of the Mississippi Miracle and what this means for the adults in the room. So hopefully you caught the news a couple of weeks to months ago from Croy, this very humble pediatrician from Mississippi, Dr. Gay, who was the one that dealt with this baby when it was first infected and presented in birth. However, it was a different pediatrician from Johns Hopkins who ended up presenting it, Deborah Persad. I'll show her on the next slide. Now let's go over the facts of what happened. So this is in fall 2010. A woman presented in labor at 35 weeks gestation without any prenatal care at all in rural Mississippi. I think the closest city here was Jackson. Now let me just pause here, and while this has been very sensationalized, and this is sort of the big headline from Croy, this is absolutely a travesty that in our modern culture in the United States of America in 2010 that a woman would present with no prenatal care just because she's black and poor in southern Mississippi. So that's my editorialization there. She was basically in labor already, and her HIV test was positive, which is very appropriate. That's what should have been done in that case. Unfortunately, the delivery was precipitous, and there was no chance for any PMTCT to be given at all. And here's just filling out the rest of her labs, which eventually came back. Her Western blot was indeed positive, and her viral load was 2,400, so a relatively low viral load, but not definitely not 0, and not less than 1,000. And her T cells were 644. This baby was felt to be fairly high risk, and so was transferred to the University of Mississippi, where she saw Dr. Gay at about 30 hours of life. And blood was drawn for multiple studies. Just like I mentioned, a high-risk baby, you have that option to do testing at birth, even though 14 to 21 days is really the first recommended time to do these nucleic acid tests. Both of these were positive. They did a DNA PCR as well as a PCR, which showed a viral load of 19,812. So although some people have said, well, was this baby actually infected? You can say absolutely yes, based on just this criteria alone. You have 2 nucleic acid tests. Granted, they should be separated in time, but the DNA PCR does show that there were PBMCs that were indeed infected. So she was given AZT, 3TC, and nevirapine. And Dr. Gay actually was a little more aggressive than guidelines and gave treatment doses of nevirapine starting 30 hours at birth. And I doubt that she had these results back by then. So she was actually going a little bit off label and being more aggressive than typical PMTCT guidelines would have had her be. Here is the viral loads in the baby that basically happened subsequently. You can see this baby had a lot of blood drawn. The initial viral load, 19,812 copies per ml. You can see the red down here denotes the regimen that she started on through 7 days of life. And what I think happened here is that the PCRs probably came back, indicating that the baby was indeed infected. And so Dr. Gay switched to a more aggressive treatment regimen with lopinavir, ritonavir, as well as AZT3TC. The viral loads fell appropriately. This is kind of what is seen when therapy is started initially, and eventually became undetectable by about a month of life. And then this baby was followed in the pediatric HIV clinic, basically, and all these little circles are different viral loads that were sent. You can see a lot of undetectable ones. And then what happened at around between 15 and 18 months of age is that the baby was lost to care. And there's a little controversy here as to when the baby actually stopped ART, but the mother basically said that after the 15-month visit, she no longer gave the baby any of her antiretrovirals. The baby and the mom showed back up into care at 18 months of age, and then subsequent viral loads were actually negative. So the baby came back, and everybody thought that the viral load was going to be way up in this, having not been on therapy for several months, but in fact it wasn't. And you can see it was checked even 3 subsequent times. The other tests here were more interesting here. So the HIV RNA was undetectable. The ELISA became negative, and people said, "Well, are you sure you had the right baby?" And I'm assured that genetic testing was in fact done. This was the same baby, but this is a phenomenon that's often seen when babies are treated very, very early. The ELISA actually does seroconvert in most cases, so that's not too surprising. But then the DNA PCR was negative as well, so this indicates that the baby truly didn't appear to have much HIV left. And so this is where Dr. Gay contacted several other investigators at Johns Hopkins and the University of Massachusetts, as well as UCSD, to have the ultra sensitive assays done to see if there was any HIV left in this baby. And this is on the next slide here. And what you see here with a lot of very complicated assays here, a lot of blood being drawn, a lot of millions of cells being looked at, is that there are only very, very trace elements of HIV left here. And many would argue that this is so low, these levels, that it's basically hard to say that this isn't just noise from the assay being picked up here. You see one copy down here from residual viremia at 24 months. And the others have very, very low levels of HIV genetic material. So this is why we talk about this as a functional cure. Nobody knows what's going to happen as this baby grows up, whether these very low numbers are going to become greater. But essentially this baby is off of antiretroviral therapy. The CD4 cell count from this baby appears to be in the normal range, and basically very little or none of the HIV genetic material can be found. So what are the implications of here? What are the key points? As I mentioned a little bit earlier, this is a problem, highlights a problem of our system of care. This woman really should have had prenatal care, and pediatric HIV, when it's managed appropriately, is virtually 100% preventable. We know very, very good numbers from Jane Hittie's group at the University of Washington. I believe there's not been really a transmission event in, I think, a decade or so. If there has been one, it's been one that was really a woman not in prenatal care. If the baby truly was infected, and like I mentioned, there are some that are still doubting whether the baby was infected, it's very different from traditional PMTCT, which is current practice. As I mentioned, Dr. Gay was more than usual with the regimen that she chose. She dosed her nevirapine really at a higher level. The baby was given, I mentioned that here, nevirapine, which is slightly more aggressive than current practices. Usually guidelines suggest 2 drugs, and the third is kind of optional. And I mentioned that the baby, was the baby truly infected? It does appear that because the 2 initial PCRs were positive right at the moment the baby came out of the birth canal, that this baby might have actually been infected in utero. Of course, really go back with a retrospectoscope and see that for sure, but it does kind of indicate that this baby was in fact infected. So the final points here are that with good prenatal care and with good PMTCT, pediatric HIV infection is rare in the developed world. Really less than 2% is the cumulative number that we use. But in practice, I think it's really closer to 0. In terms of pediatric HIV infection, it's really a problem of no prenatal care where HIV transmission still does occur in this setting. Of course, in the developing world, it's really a fully different and a different battle. The second point, that's a real practical one, is that diagnosing or excluding HIV infection in a neonate requires 2 separate nucleic acid-based tests, and this can either be done at this defined windows that I mentioned, starting at 14 to 21 days, or you can do that optional one at birth, which is done in practice a lot that I've seen. Thirdly, evidence really supports initiating ART in all infants less than 12 months old because of the extremely high mortality at the young ages and the incredible benefit of ART at young ages as well. And then finally, antiretroviral agents have complex and variable approved and recommended age restrictions, and you can use the DHHS guidelines. They're really very well organized in terms of telling you what is acceptable in different age groups. Hopefully I've given you a visual picture of it in the slides, but again, if you have an HIV infected infant, this is really in the turf of a pediatric ID person who can hopefully help you out. Thank you very much.